Hello everyone, welcome to our channel. Today we are going to discuss about the pediatrics rapid revision lecture as part of our mission to 100 plus. So almost we are nearer to the examination, guys. More 10 to 12 days we can see. So in this period, very crucial that you have to going to revise the only rapid revision high yield topics and previous year topics only. So don't run behind the PYQs. Always focus on the PYTs rather than focusing on the PYQs, and make the time maximize for you, and you can practice well for the all types of the MCQs. For the using of the hashtags also, try to use all kinds, because nowadays exam is unpredictable. Okay, try to use all the patterns of the hashtags and also PYTs focused MCQs. Okay, not just PYQs. So let's start today's discussion, pediatrics rapid revision. So let's start with the first topic, that is APGAR scoring. So in the APGAR scoring, the most important, we have A for appearance, P for pulse, G for grimace, A for activity, and R for respiration. Next, appearance. So how many points we are going to given? 0, 1, 2. So 0 point for the cyanotic, 1 point for the peripheral cyanosis, and 2 points for whole pink baby. So whichever we are giving the 2 points for, this is normal. Next, pulse. So if there is no pulse at all, we can consider this as a 0. If it's less than 100, 1 point, and more than 100, that is 2 points. Next, grimace. Grimace is irritability. When you touch the baby, if baby is irritating, that is known as a grimace. So while we are touching, there is no response to that stimulation, that is 0. And grimace, like small minor grimace and the weak cry, then it is 1 point. And crying immediately after the stimulation, baby started to cry a lot, then it is considered to be the 2 points, and it is normal. Next, activity. Baby is floppy is 0, some flexion 1, and well flexed with a resting extension. This is normal and considered to be the 2 points. Next, respiration, no respiration at all, it is 0, and slow and irregular 1 point, and strong cry 2 points. Okay, this is how we are going to do. And how we are going to do, in the first 1 minute you are going to check, and also 5 minutes. And this will help us to understand how the baby is present. Next, other scores also present, that is Downey score. Next, Silverman Anderson. Okay, Silverman Anderson score is also present. Next, we Downey score we are going to use for the term babies, those who are with the respiratory distress. And Silverman underscore we are going to use for the preterm baby. Again, same for the respiratory distress. Right? These are the important scores and what are we are going to do. And APGAR is seen for the all patients, whether it's a term, post-term, and also preterm, all the babies that we are going to do at the time of the birth, 1 minute and the 5 minutes. Next, moving on to the neonatal resuscitation. So what does mean by the neonatal resuscitation? Immediately after the baby is born, what you have to check, the tongue and tone and cry. So these three will tell us whether the baby is normal or not. So if it is a less than term, then it is likely to be respiratory distress syndrome seen. If there is a no good tone, the baby is floppy, so there will be flaccid paralysis. If baby is not crying properly, then breathing will be decreased, and cyanosis can cause hypoxia can cause seizures. So that is also important. Next, if you see any of one dysfunction also, if the term is not good, if the tone is not good, if the breathing is not problem, immediately warm up the baby and position the airway, clear the secretions as need as possible, and next dry and stimulate the baby. Okay, this is the first step should be done for the first 1 minute. Next, even though after that the baby is showing the apnea and gasping, and heart rate is less than 100. Okay, so here less than 100 heart rate, then what you have to do, you have to immediately move to the positive pressure ventilation. So immediately positive pressure ventilation should be done for the baby. Even though after that also still heart rate after in the first 1 minute we are done, positive pressure ventilation is also attached. Even after that the baby is not still accompanying the whatever the circumstances, and heart rate is still less than 100, then what you have to proceed, you have to start the chest movement. Okay, check the chest movement and start the ventilation steps. What are those ventilation steps? For example, you can intubate the baby, or you can start the laryngeal mask airway. Then also, if the still baby is heart rate is less than 60, then what you have to do, you have to intubate and start the chest compressions, and also consider the urine umbilical venous catheter. Okay, better to consider the umbilical venous catheter. And next, still if it is still heart rate is less than 60, then you have to give the IV epinephrine, and heart rate is persistently below, then you have to consider for the pneumothorax or the hypovolemia for this baby. Right, these are the important steps that should be done immediately for that baby. Okay, so golden 1 minute is the this one. So we in this period only you have to start the positive pressure ventilation, and this is the important steps for the neonatal resuscitation and commonly asking questions for the examination. Next, moving on to the this reflex, you all know this is known as a Moro reflex. So what is mean by the Moro reflex, guys, and in which patients Moro reflex is absent and which patients and abnormal Moro reflex will be seen. So we all know that Moro reflex will be having the two phases. Okay, so first phase 1 you are going to see. So phase 1 you are going to see abduction and extension. Okay, so the baby will be moving towards periphery and then extend their hands. Okay, the extension of the arms with open hands. Okay, this is how you are seeing. Next, phase 2. In the phase 2 you are going to see adduction and flexion. Okay, adduction and flexion. So this is seen in the patients, this is seen in the normal fetus. Okay, absolutely, this is normal primitive neonatal reflex. That means the what does the Moro reflex is telling us, that the CNS is normal. Okay, the CNS function is intact in this baby, and when it is going to present at birth only, we are going to see this Moro reflex, and it will disappear. It will disappear by 4 to 6 months in the baby. Next, in which patients it is absent, and unilaterally, if I say unilateral Moro reflex is absent, then it is Erb's palsy, right? Due to the nerve root that is damaged, that will be seen. Next, complete absent. It is seen in the hypoxia patient. Okay, hypoxia encephalopathy or the prematurity in these babies, we are not going to see this one. Next, excessive. Okay, excessive, that is seen in the toxicity and hypocalcemia. Okay, and this is how a Moro reflex and commonly associated in the patients that we are going to see. Next, we are here discussing for the kernicterus. What does mean by the kernicterus? Based on this condition, you can see the patient is suffering from the kernicterus. What is kernicterus? Before that, we have to know about the jaundice, physiological and the pathological. So we have the two kinds of the jaundice. One is physiological and other one is the pathological. Okay, so physiological jaundice, that means the baby is having the jaundice after 24 hours of the birth, whereas pathological, it is less than 24 hours or even by birth the baby is having the jaundice. And what is the difference between this? Usually it is going to be conjugated bilirubin elevation, and here unconjugated bilirubin elevated. Okay, this is the difference between the physiological and pathological. Usually, the increase in the bilirubin is almost 5 milligram per DL only, and it will be less than 14 days. And it is more than 5 milligrams. Even severity more than 50 milligrams will be seen, and more than 14 days will be also seen. And most common cause for this one is the RH incompatibility. The most common cause for this is the biliary atresia. Biliary atresia. So when the pathological, what happens, if it is more than 15, it can cross the blood-brain barrier. Okay, when it is crossed the blood-brain barrier, it will involve the basal ganglia. Once this basal ganglia is involved, so this is how the baby is going to happen. So this condition is known as a kernicterus. That means this bilirubin is crossed the blood-brain barrier and made the deposits in the basal ganglia. Irreversible damage will be seen in the baby. That is the first thing that you have to understand. Next, what is the treatment protocol? Physiological, it will disappear without the treatment also. But pathological, you need the phototherapy and also you need the exchange of the transfusion should be done. Okay, this is the difference, and here the condition of the kernicterus. Next, moving on to the necrotizing enterocolitis. So necrotizing enterocolitis is commonly seen with the what is the most common cause for this guys? Prematurity. Okay, it is prematurity due to preterm. That is the commonly seen in this patient. This is the most common cause, and also formula feeding. Those who are not breastfeeding, formula feeding is also associated with the necrotizing enterocolitis. What is the most common cause? Usually what happens, our intestines, when the baby is born less than 35 weeks or the 34 weeks, intestines are immature. Okay, so this will cause the motility is decreased. So what happens, the ischemia is also causing. So these ischemia will involve the bacteria. Okay, gut bacteria will be replaced with the normal bacteria and then lead to inflammation, enterocolitis, right? We have discussing enterocolitis. Inflammation will be seen and this will lead to the necrosis, irreversible damage to the intestine. Here you can see this is the abdominal distension, and on the X-ray pneumatosis intestinalis. So this is the gas bubble, and here whatever that first layer, clearly you can see the air is filled. Next, this is the inflammation, and after over the while the necrotic bowel. So this is the common features that is associated with the necrotizing enterocolitis. Okay, next. Another thing that you have to remember for this patient is usually the pathognomonic sign is here. Pneumocystis intestinalis is the pathognomonic sign. Next, what is the staging we use here? The Bell's staging we commonly use in this patient. Okay, Bell's staging we use. Okay, first, usually in the stage 1 mild distinction, immediately you have to work up. If it is a definitive, the already the progression is seen to the necrotizing tissue, then you have to go for the surgery immediately to prevent the perforation and peritonitis condition. Okay, and next, patient treatment, you have to be NBM, no nothing for oral, and also OGT or the NGT tube should be given for the decompression, and high antibiotics should be started, and before that we have to proceed for the surgery to prevent the necrosis. Okay, IV fluids is also given for this patient. So this is the necrotizing enterocolitis. Next, moving on to the neonatal sepsis. So in the neonatal sepsis, we have different types. One is early, okay, another one is the late. So early neonatal sepsis is usually 72 hours of the birth or less than 7 days of the birth. Okay, next, neonatal late neonatal sepsis is more than 72 hours and then less than 28 days. Okay, this is, so what are the causes for this? In the early, the most common cause is vertical from the mother, and the common cause will be GBS. And in the late neonatal sepsis, it is due to hospital acquired, and this is Klebsiella. Okay, this is Klebsiella. So these are the commonly that we are going to see with the neonatal sepsis and their cause. What happens? The patient will be having the sudden rise of the fever, respiratory distress, shock-like symptoms, poor feeding, refusal to feed. These are the common presentations that we are going to see. And what are the things that you have to do? Sepsis screen should be done. So on the sepsis screen, you are going to see CRP will be elevated and absolute neutrophil count will be decreased. Okay, this count will be decreased. Immature neutrophils will be raised. Okay, immature neutrophils will be raised and ESR is raised, and sometimes platelets is also decreased in this patient. Then what is the gold standard? Okay, the gold standard for this patient is culture. Culture should be taken immediately and start the antibiotics as soon as possible and prevent the shock for this patient. Next, moving on to the some of the important respiratory diseases. So first, here going to discuss about the RDS, respiratory distress syndrome, which is also known as a hyaline membrane disease. So what is this condition, guys? Let's discuss. So first, it is commonly associated with the preterm babies, okay, less than 34 weeks of the age, and also diabetes mellitus mother, those who give birth, they also associated with this condition. So what happening here? There is a deficiency of surfactant. Okay, so surfactant is important, but if there is no surfactant, what happens? There is an increased risk of tension and also decreased compliance, which will lead to collapse of the lung tissue. So when there is no surfactant in this baby, we on the chest X-ray, you are going to see the white out lung. Okay, white out lung, because no compliance, no air inflation will be seen. So completely there will be whiteout lung we are going to see. And this is only known as a air bronchogram sign. Air bronchogram sign will be positive in this condition. So these all thing is happening due to lung collapse due to surfactant deficiency. What is the treatment that we can give for this patient? That is insure. Okay. The technique name is insure. So here you can see this is the insure. Insure means intubate, give the surfactant, and restitute means remove the intubation. So that is here. So we are going to give the artificial surfactant. Artificial surfactant should be given for this baby. That is the treatment protocol. Next, moving on to the transient tachypnea of newborn. Transient tachypnea of newborn. So in this condition, this is also known as a wet lung, and this is seen in the term babies. Okay, this is seen in the term babies. So what happens in the transient tachypnea of newborn? The name itself telling it is transient condition. So why it is a transient condition? Especially the mothers, those who are suffering from the asthma, the mothers, those who are suffering from the other lung diseases, so diabetes mellitus. What happened here? So even though during the term life also, the whatever the fluid that is present in the birth, okay, will be in the lungs only. So immediately after the birth, they have to release that fluid and they have to inhale, right? So where this fluid is still present in the lungs, which will be causing the transient tachypnea syndrome. Okay, and on the chest X-ray, you are going to see the perihilar streaking, and also fluid will be seen. Fluid will be seen in the interlobular fissure. Here you can see here. This is how the perilobar is streaking and also fluid near the interlobar fissure that we are going to see. And next treatment is going to be within the 24 hours, transient. So 24 to 48 hours the improvement will be seen. Only the supportive treatment O2 therapy should be given for the baby. Next, meconium aspiration syndrome. This is seen in the post-term babies. Okay, and in the post-term babies, especially what happens, post-term means they are going to meconium easily. So when they are going to leak the meconium, and if it is already mixed with the amniotic fluid, what happens? The aspiration will be causing, right? So aspiration of the meconium into the lungs, which will be causing the meconium aspiration syndrome. So which will be further increase the respiratory distress, and pulmonary hypertension will be seen in this condition, which worsens the condition of the patient. So for the X-ray, chest X-ray, you are going to see the findings of hyperinflation and sun rays appearance. Okay, sun ray appearance you are going to see like this. Okay, the sun ray appearance, and here you can see there will be a hyperinflation will be seen in this condition, and over the time the collapse will be also seen. Atelectasis and collapse of the lung will be seen in this patient. And what is the treatment protocol? And oxygen therapy immediately you have to give. Along with that, you can also give the IV or inhaled nitric oxide. And what is the drug of the choice if there is a pulmonary hypertension in this patient? That is sildenafil, okay, or Viagra. These drug can be given in the minor doses for the baby to vasodilate those vessels. Okay. Next, moving on to the breastfeeding. So this is the exact and proper position. Okay, how the proper position should be done? First, it should cover the mouth. Okay, mouth and upper lip should cover entire areola. Okay, next, and the lower lip should be flanged out. Okay, the lower lip should be flanged out. And how the mother should hold near the head and trunk. So this is the exact position. After that, there should be a burp. So burping should be seen. If not, there is going to be the risk of vomiting and aspiration. Okay. Next, how many months we have to give? At least 6 months exclusive. Okay. 6 months exclusive will be given. Next, after that, complementary food will be started after the 6 months. So complementary plus breastfeeding is done until 2 years of the age. This is how we are going to see. Next, what about the contraindications? The absolute contraindications. Absolute contraindications will be lactose intolerance. Okay, lactose intolerance along with the baby, those who are suffering from the galactosemia, and mother, those who are taking the radio or the chemo. This is also contraindication. Next, relative contraindications. So those who are suffering from the HIV or active TB or TB therapy, those who are taking active CMV, active herpes lesions near the breast. So these are also contraindicated. Next, those who are taking the antiretroviral therapy also is not given nowadays, but accordingly it is changed by the over the time. So these are the relative contraindications in the baby. Next, another thing that you have to remember is the colostrum. What is this colostrum, guys? Which will be containing the IgA. So this is the first immunization we can say. So these immunization in the first milk. This is the first milk that the baby is going to have, and it is looks like thick yellow color and which will be rich in the fat. Okay, it will be rich in the fat and low in the protein, but it is very healthy for the baby. And after that, whatever the milk is coming, so that will be high in the protein and low in the fats. So this is the some difference that you have to understand. Next, feeding patterns. So in the feeding patterns, usually if it is less than 28 weeks baby, then we have to total parental nutrition is given for this babies. If it is 28 to 31 weeks, then it is given via nasogastric tube breastfeeding is given. So you have to pump the breastfeeding and then you have to give the baby. Okay. Next, 32 to 34 weeks. In this katori spoon, we are going to use or paladile will be used. Next, more than 34 weeks, already this is going to sucking reflex will be normal. Then it is going to be breastfeeding only. Okay, via oral breastfeeding that is given for the baby. That is the one another feeding patterns that you have to remember. Next, moving on to the growth. So in the growth here, these are the two charts that you have to remember, guys. So what are these two charts? This is for the boys, blue color is for the boys, and here the pink color is for the female. So this is given by the WHO criteria. So before that, we will see small growthing patterns. So this is the graph. Okay, here this is going to be the percentage. Okay, and here it is going to be the age. So this is at birth. Okay, this is the 10 years and here it can be 20 years. Okay, right. Let's see. So first we are going to discuss about the how the brain growth is seen in this patient. Usually the brain growth at the birth is going to be less only. So over the time brain growth will be increased, right? Next, coming to the lymphoid growth. So lymphoid growth will be maximum seen at the 10 years of age. Then again it will decrease. Okay. Then we are going to looking at the gonadal growth. So gonadal growth is also going to increase after the age, puberty of the age. Okay. What about the normal somatic growth? So somatic growth will be achieved in the babies again after the age of the 10 only. Okay. So the somatic growth will be also seen after the 10 years of the age. Okay, after the 10 years of the age you are going to see. This is how the normal patterns of the growth will be seen. So this is for the growth spurt. Okay, this is for the lymphoid, this is for the brain, and this is for the this is for the gonadal growth. Okay, remember this guys. Next, moving on to the weight. Okay, again, this is for the boys and this is for the girls. WHO charts. Next, for the weight gain. So usually what happens, average weight gain and normal is 2.9 kgs. Okay, normal is 2.9. Then we have to also know about the what is the weight gain pattern. So usually it will double the birth by 5 to 6 months and triples by 1 year and 4 times quadruples by 2 years. Okay, this is normally we see. Next, height average height will be the baby average height will be 50 centimeters. Okay, 50 centimeters by 1 year. Okay, by 1 year it is going to be 75 centimeters, and by 12 years or sorry, by 2 years it is going to be approximately 87.5 centimeters. Okay, by the time of more than 2 years to puberty, okay, it is not going to be unchanged. So per 6 centimeters per year they are going to increase. So this is the pattern, and when they are going to double will be seen at the 4 years, double will be seen in the 4 years, and triple will be seen at the 12 years. Okay, triple will be seen at the 12 years. Next, another thing that you have to remember here is the mid arm circumference, mid upper arm circumference. So mid upper arm circumference, this is used for the nutritional status assessment for 1 to 5 years of child. Okay, and how we are going to use the Shakir tape is used. The Shakir tape is used. So the Shakir tape will be containing of green color, which will be normal. Okay, more than 12.5 centimeters. Next, another one is the yellow. So this is the mild condition and malnutrition, 11 to 5 and 12 to 0.5 centimeters. Okay, next, red color. This is severe. This is less than 11.5 centimeters. This is for the mid upper arm circumferences. Okay, this is also important. Next, we will be discussing about the head circumference. Okay, head circumference, usually at birth the normal is 33 centimeters. Okay, 33 centimeters. For the first 3 months, it is going to be 2 centimeters per month. Okay, next, until 6 months, it is going to be 1 centimeter per month. Right, this is how you have to remember the head circumferences, and these are the some of the important things that you have to remember for the anthropometric measurements. Now we are going to discuss about the marasmus and the kwashiorkor. This is the protein malformation and also the whole calorie calorie malnutrition. So let's see the differences here guys. So the first thing here, you are observing the patient with a marasmus. So in the marasmus patient, what happened in the marasmus patient, usually they are going to be complete deficiency, right? Complete nutrient deficiency that we are going to see here. So calorie, the whole calorie deficiency will be seen with the marasmus. Whereas the patients with this condition, here you can see these are kwashiorkor. Most commonly they are associated with the protein. Okay, they are associated with the protein deficiency. For the condition of the marasmus, what happens? These patients with the marasmus, how they are looking guys? They are looking like a old man, right? So the old man, this baggy pant appearances that will be seen. Okay, monkey faces and old man baggy pant appearances. So these all are seen in the patients of the marasmus. So these patients, commonly those who are suffering from them, what happens? The edema is not seen. Okay, edema is absent here. This patient will be alert and irritable and voracious appetite. Okay, voracious appetite will be seen. and this condition is having the good prognosis. Good prognosis is seen. Next, coming to the kwashiorkor, you are going to see edema and belly will be seen. This belly is due to hepatomegaly. And what happens? This patient will be also associated with the lethargic, okay, poor appetite, and high risk for the heart failure. So this is poor prognosis. Okay, this is associated with the poor prognosis. What are the signs that you are going to see in this patient? So like this, the peeling skin is seen. So specifically the dermatitis will be seen in this condition. And also in the hair, there will be a flag sign. These also seen. But for this, we need the criteria. Okay, the WHO criteria that we need for the severe acute malnutrition. So what is the WHO criteria? The weight to height. Okay, the weight to height, it should be less than -3 standard deviation, and edema which will be not cardiogenic, and mid upper arm circumference is less than 11.5 centimeters. So if this criteria is visible, if this criteria is seen, then we can consider this patient as a severe acute malnutrition. Okay, this is the criteria for the growth chart. Next, what about the treatment for this patient? So there is a treatment protocol as per the WHO. There are the two phases. One is stabilization for the first 7 days. Okay, next, rehabilitation, and this rehabilitation will be for 6 weeks. Okay, after the first week we are going to give the 6 weeks rehabilitation. So in this, we have to prevent the hypoglycemia, hypothermia, dehydration, infections, nutrition deficiency. All this should be done, workup will be done. And always remember, by the time of the discharge, the patient should not have the edema, and at least this -3 standard deviation protocol, these WHO criteria should be removed, because he should be weight gain in the rehabilitation phase. At least 1 to 2 standard deviation should be seen, and also MUAC also should increase for the 12, or at least 12.5 centimeters should be seen for this patient. This is the treatment protocol. The milestones, first we are going to see about the gross motor. So gross motor will be following the cephalocaudal, guys. So for example, 3 months neck holding, okay, 3 months neck holding, and 4 months rollover, 6 months baby is going to sit but with support, okay, 8 months sit without support, next 10 months stand with support, next 12 months the baby is going to stand again, but again this time is also without support. Okay, 15 months walk without support, and 18 months running, 3 years tricycle riding, okay, 3 for tricycle ride, and 4 years climbing and hopping, okay, climbing and hopping will be seen. So these are the gross motor. Next, coming to the fine motor. So in the fine motor, usually important ones only we will be remembering. First, at 4 months there will be a bidextrous grasp. Okay, next 6 months unidextrous grasp. Next 9 months immature pincer grasp. Okay, holding fingers like that. This is going to be the immature pincer grasp. Next 12 months it is going to be mature pincer grasp. Mature pincer grasp. Possibly all the fingers will be used so to hold that object. Okay, that is first thing. Next 15 months baby can make the 2 cube tower. Okay, next 2 years, 2 years to 2 ends. So able to draw the line. Okay, that is the first thing. Next 3 years, circle, the baby can make the circle, and 4 years is going to be the cross. Okay, 4 ends. So 4 ends. So that is cross. Next 5 years, triangle. Next, moving on to the language milestones. Okay, language milestones. So in the language milestones, usually at the 3 months, ku, ku will be seen. Okay, 6 months, monosyllables, and 9 months, bisyllables. Okay, 1 year, usually 1 to 2 words. Okay, one for 1 year, one for 1 word. Like that also you can remember. 18 months, 8 to 10 words, and 2 years. Baby can also tell the sentence. Okay, at least one sentence will be tell. Next 3 years. In the 3 years, baby, you are going to see three things they are going to tell: name, gender, and also age. So they're able to recognize about their things. Next, coming to the social milestones. Okay, social milestones. At 2 3 months, they are going to know about the mother. So the mother attachment, or we can say the mother regard, will be seen in this patient. Next, 6 months, stranger anxiety. So 6 months, there will be a stranger anxiety will be seen, and 9 months, peekaboo. Okay, 9 months peekaboo, and also bye bye will be seen in this babies. Next, moving on to the 1 year, they're going to play the game by themselves. Okay, and 2 to 3 years, baby can play with other people also. Okay, so play parallelly, and 4 years, they will be able to attach the groups. Okay, so 4 years they are going to be group. So this is seen in the socially. Okay, these are the important things that you have to remember when it is comes to the milestones. Even if they given together also, you have to answer this one. Next, moving on to the diseases here. This is known as a Kawasaki disease, right? In the Kawasaki disease, what is the most important thing that you have to remember? This is known for the medium size vasculitis. Okay, this is known for the medium size vasculitis. So Kawasaki disease usually associated with this condition. What are those things, guys? Fever will be seen in this patient. Okay, the fever will be more than 5 days and not responding to the antipyretics or the antibiotics. Along with that, any of four conditions. Okay, any of four symptoms. It could be conjunctivitis, or it could be poly almost polymorphy rash will be seen. Okay, the rash will be seen in this cases, edema. Okay, and lymph adenopathy, especially in the cervical region, and strawberry tongue. Okay, these are some of the features that is present. Any four, okay, any four plus fever, then it is considered this as a acute phase of the Kawasaki disease. So but what is the risk if there is a Kawasaki disease? So these Kawasaki disease can increase the myocardial infarction, or it can increase the aneurysms. So it can also increase the heart failure. So any of this causing, which will be very detrimental for the child, right? Myocardial infarction or the aneurysm in this age, this is going to be very difficulty. So what is the treatment dosage? The treatment is IVIG. Okay, as per the body weight we have to give, and other drug we can give is the aspirin. Aspirin can be also given for this babies. Next, moving on to the rheumatic fever. So what we discussed in the rheumatic fever, guys, mostly this rheumatic fever is due to strep. Okay, this strep infection is going to form the antibodies. So when these antibodies going to react, cross reactivity, which will be causing the rheumatic fever. So if this rheumatic fever is progressed, it can cause the rheumatic heart disease. Okay, so these cross reactivity, or which we also known as a molecular mimicry. is going to cause the rheumatic fever. So rheumatic fever features will be, patient will be consisting of the fever, increased ESR levels and increased CRP levels. First thing. Next, along with that, there will be a Jones criteria. So what is this Jones criteria? J for the patients will be associated. Here you can see the joint pains, arthralgia or the arthritis, carditis, nodules, erythema marginatum and Sydenham's chorea. So how much is this association will be seen? For example, if you see the joints is involved. So it is likely to be most commonly affected by the rheumatic fever. Okay, and this is carditis, which can be progressive to the rheumatic heart disease. And here nodules are very rarely seen, but if they are seen, it is associated with the carditis. Okay, 100% it is associated with the carditis. Next, erythema marginatum. Okay, erythema marginatum. But this is also seen but not very familiar to association with the carditis. Next, subcutaneous nodules here. Sorry, this is the not subcutaneous nodule. This is chorea. Okay, this is Sydenham chorea. Sydenham chorea is very late symptom. Okay, acute symptom, early symptom is joint pains, but late symptom is the Sydenham chorea, and there will be associated with the darting tongue. Okay, milkmaid grip and dancing. Okay, this is seen with the Sydenham's chorea. And what is the treatment of the choice? And treatment of the choice for this patient will be the penicillin. Okay, penicillin will be given as a treatment. Okay, benzathine penicillin is given, and prophylaxis is also done for this patient. And rheumatic fever, if it is progressive to the rheumatic heart disease, most common valve that is involved is the mitral, and in that abnormality, mitral stenosis, right? And on the histopathology, you are going to see the Ascough bodies. Ascough bodies will be seen due to the inflammation of the rheumatic heart condition. These all points will be most important for the examination. Next, moving on to the heart diseases, guys. Congenital heart diseases. So congenital heart diseases, first you have to remember these congenital heart diseases are divided into cyanotic and non-cyanotic. So cyanotic, we have the commonly tetralogy of Fallot. Okay, almost all are going to be the T only. For example, tricuspid atresia or total anomalous pulmonary arteries, and also we have the transposition of the great arteries. All these will be mostly cyanotic types. Okay, next we also have the others like non-cyanotic, AST, arterial septal defect, or VST, or patent ductus arteriosus. These all are going to be the non-cyanotic. So most common cyanotic is uh, tetralogy of Fallot. Non-cyanotic most common is the AST. And in this most common also they ask, that is ostium secundum is the most common type. And the VST, it is going to be membranous type of the VST is going to form. And what are the murmurs that is associated with these things, guys? First, we will see some of the important points and chest X-ray findings. So this is tetralogy of Fallot. So the boot-shaped heart will be seen. Next, here, this is the Ebstein's anomaly. So important point about the Ebstein's anomaly. So this is associated with the lithium, right? This is associated with the lithium, and box-shaped heart you are going to see in this condition, right? Next, here, first we will see this one. This is the transposition of the great arteries. So usually the diabetic female infants is going to have this condition, transposition of great arteries. Next, here this picture, here this is the condition of the total anomalous of the pulmonary veins. Okay, this is total anomalous of the pulmonary veins, the snowman. Okay, this is known as a snowman, or also known as a yite shape. Okay, yite shape appearances. Why? Because this is the total anomalous of the pulmonary veins, guys. Usually it has to be in the left atrium, but it is going to be in the other side of the right atrium, that will be causing this kind of condition. So this is known as a supracardiac type or the snowman. Next, this is a partial. Okay, this is known as a partial anomalous, guys. Partial anomalous of the pulmonary venous. This sign is known as a Smitter sign. Okay, Smetter sign that is seen with the partial time. This is total time. Next, another one is the coarctation of iota. Coarctation of the iota, where you are going to see this rib notching. Rib notching will be seen, and also three sign here. Three sign. These are seen, and this is associated with the Turner syndrome. Turner syndrome. Next, other important points that we have to discuss here. First, let's discuss about the tetralogy of Fallot. So, tetralogy of the Fallot will be having the four criteria. First, it is going to associate with the pulmonary stenosis. Okay, then right ventricular hypertrophy and VST, ventricular septal defect, and overriding of aorta. Overriding of iota. So the most important or the factor that is here, pulmonary stenosis. This is the one which is going to cause this detrimental of the condition. Next, boot-shaped heart that we are going to see. Next, another one you have to remember, Epstein's anomaly, lithium exposure that is seen. And coming to the AST, what we discussed here, AST will be associated with the ostium secundum type, right? In the ASD, the murmur will be ejection systolic murmur. Okay, ejection systolic murmur. And in the VST, you are going to listen the ejection systolic, and delayed diastolic. Okay, delayed diastolic murmur. Next, PDA, patent ductus arteriosus, which is mostly associated with the rubella syndrome. Okay, they are going to have the continuous murmur. And those are the important signs that you have to remember. So these are the some of the findings and congenital heart diseases and rheumatic heart fever. Next, we are moving on to the IMNCI guidelines. So in the IMNCI guidelines, you have to take note of the two topics, guys. One is about the pneumonia. So one is about the pneumonia and other one is about the dehydration. So first, before you have to know about the pneumonia, you have to know about the respiratory rate, what is normal. So if it is more than 60 in the newborns, okay, in the newborns, if it is a 60, that is likely to be tachypnea. And if those who are 2 to 12 months, if it is more than 50, this is also tachypnea. And more than 40, so 1 year to 5 years, then it is considered to be the more than 40 is the tachypnea of the rate. So next, coming to the criteria. So the green color one is always going to be normal. So these are the three categories that you are going to give, guys. So first, for the pink color, this is severe condition. Okay, this is severe condition. So this is also known as a severe pneumonia. Okay, next, in the severe pneumonia, what you are going to see, the signs of the severe pneumonia is going to be the generally the patient will be having the symptoms, whatever the pneumonia symptoms that is present. Along with that, you are going to see the chest indrawing. You're going to see the chest indrawing and danger signs is seen. Okay, danger signs is also seen in this condition, like vomiting, lethargia, this is seen. So for this patient, what is the treatment protocol that you are going to do? The treatment immediately for this patient is refer the higher center, and along with that, you have to give the first dose of antibiotic. So IV antibiotic will be given for this baby. Next one. So here this is the yellow category, which is known as a pneumonia. So here only the fast breathing is seen. Only the fast breathing is seen along with the pneumonia symptoms. So give the oral, the treatment will be give the oral antibiotics. Give the oral antibiotics for 5 days and follow-up should be given. Follow-up should be done for this patient. Next one. So this is the green category, no pneumonia. This is no pneumonia and only the cough or the patient will be having the cold. Generalized symptoms only. For this patient, supportive. The breastfeeding should be given and whatever the importance, like antipyretics or fever is coming, then like common symptoms will be supportive treatment will be given for this guidelines of the pneumonia. Next, we have the another category, that is diarrhea, right? So for the diarrhea condition, you are going to see the IMNCI guidelines, same pattern. So how, but this is divided. For example, if you see, there is a three different classes. One is severe dehydration. So what does mean by the severe dehydration? The patient will be lethargic. Okay. Along with the lethargic, there will be a unconscious or stupor like, and also the dry tongue. Okay. Dry mucous membranes, sunken eyeballs, and also the whatever we are going to check capillary refill time, that will be also very slow. Okay, these are the some of the signs for the severe dehydration. Urine output will be completely decreased in this babies. What is the treatment protocol that you have to give? Always go for the IV fluids. Okay, regardless, IV fluids will be given for this baby. And along with that IV fluids, ORS fluids can be given as per one episode also. Next, antibiotics is also given for this baby. Next category is the yellow category, and in this yellow category, some dehydration. Okay, some dehydration. So some dehydration signs will be baby is restless, irritable, okay, thirsty, and CRT levels will be less than 2 seconds. Okay, less than or equal to 2 seconds. And for this patient, what we have to give? Supportive treatment, but ORS. For every one episode, you have to give the ORS plan for this patient. Okay, and even if they are increasing, then you have to go for the IV fluids therapy. So ORS and supportive therapy is given for this baby. Next category is the green category. So no dehydration. Okay, no dehydration. So in this no dehydration, simply the symptoms will be not associated with the not associated with the moderate or severe dehydration. Okay, so only the few episodes of lower bowel movements that will be seen for this patient, and here only the treatment is supportive breastfeeding, fluids, and rice water. All this will be given. Supportive treatment will be given for this patient. But how the plans will be associated for the patients of the supportive breastfeeding? Okay, ORS that will be given for this patient, and along in this patient, ORS plus rehydration solution. Okay, how this rehydration solution is given? 75 ml per kg. Okay, that's how we are going to give, and then maintenance dosages. Next, IV fluids is given here. What is the formula for the holiday cigar method we are going to use for this patient? Okay, this is also we are going to use. And what is this holiday cigar method, guys? So first, in the babies of the holiday cigar, so first 0 to 10 kgs, 100 ml per kg. Okay, and next, more than 10 to and equal to 20 kgs, then 50 ml per kg. More than 20 kgs, then it is plus 20 kgs, plus 20 ml per kg. This is how we are going to give for this babies. All right, next, moving on to the another condition here. This condition is known as a bronchiolitis. So bronchiolitis, the most common cause is the respiratory syncytial virus. So this patient is usually at the 2 to 5 years of the age morely prone to this bronchiolitis infection. If they are associated, commonly this is mimicking the obstructive condition. So the patients will be having the wheezing, okay, and severe pneumonia can be seen. On the chest X-ray, you are going to see the hyperinflation will be seen, and treatment, the drug specifically ribavirin. Okay, ribavirin is given for the severe cases, but in the most of the cases, supportive treatment is definitive. Okay, supportive treatment is a definitive treatment for this patient. This is known for the bronchiolitis. Next, we will be discussing about the asthma. Okay, childhood asthma. So usually patients with this childhood asthma mostly associated with the allergic type, and This is also IgE type. Okay, IgE eosinophil types. So for this patient, immediately you have to give the SABA as per the SOS. But if they are needed for the therapy, then it is low dose of LABA along with the inhaled corticosteroids given. Okay, this is with the controlled inhaler that you have to give for this treatment. Again, the treatment protocol will be stepwise ladder treatment that you have to give as per the symptoms that we are going to find. But if there is a status asthmaticus, okay, the baby is status asthmaticus, what is the treatment that you are going to give here, guys? That is MgS44. Okay, MgS44 is given as a drug of the choice for the status asthmaticus. Okay, this is the one of the feature that you have to understand. Next, remaining things. Okay, and also you have to take note about the ORS composition. Okay, ORS composition. So in the ORS composition, we have the multiple factors. Okay, for example, what are the things that you are going to add in the ORS, guys? Firstly, we are going to include the sodium. Okay, sodium, and also glucose, potassium, and then also chloride and citrate. So sodium will be around 75, glucose is also going to 75. Okay, and potassium and chloride KCl is around 65 and citrate is around 20. Okay, this is the ORS WHO classification. Only these powders should be given for the babies. Rather than that, if there is any other formulation also, that can be detrimental and highly risk for the babies. Next, moving on to the neuro, and in the neuro you have to take note about the CSF analysis. So first, the normal will be, the patients will be having the more than, so the neutrophils and lymphocytes will be normal ratio only, and protein is also 20 to 45 normal. Glucose will be more than 50 or 75. In the bacterial, there will be neutrophils. Okay, high range of the neutrophils will be seen. Protein will be just normal, but glucose is decreased here. But comparing to the tuberculosis, protein is double the times. Okay, and viral, which will be mimicking like the normal only. Here you can see normal elevation will be seen, no neutrophils will be seen, and elevation of the protein also very slightly and underlying value only, and glucose is normal. So viral and normal will be mimicking the same. The bacterial will be morely, the WBC will be elevated. In the tuberculosis, it is lymphocytes and protein is highest, and cobweb formation that is seen in the tuberculosis only. Next, we will be seeing here another condition, guys. What is this conditions? The perinatal infections. Okay, these are the perinatal infection. So this is toxoplasmosis, and here this condition is CMV, cytomegalovirus. This is rubella, and here it is Zika virus. So before we know about the triads, let's see what are these findings of the CNS. So for example, toxoplasmosis, you are going to see the intracranial calcifications. Okay, this is seen in the toxoplasmosis. And in the CMV patients, there will be periventricular regions, periventricular calcifications are seen. Okay, next, in the rubella patients, you are going to see the periventricular leukomalacia. Okay, leukomalacia, the white color kind of thing that is seen in the rubella. Zika virus, you are already seen, there will be atrophy and the microcephaly. Okay, that is seen in the Zika virus of the patient. Then what about the triads? So the triads of these patients will be the first, coming to the toxoplasmosis. In the patients of the toxoplasmosis, you are going to see the hydrocephalus and chorioretinitis, and this intracranial calcification. Next, coming to the Zika virus. Zika virus, you are going to see the rash and also glaucoma and SNHL. So this is seen with the patients of the CMV. And rubella. In the rubella patients, you are going to see the cataract and heart disease like PDA is the most common and SNHL that is seen with this condition. Next, Zika virus, microcephaly and also contractures, and also patient will be associated with the calcifications and the atrophy that is seen. CNS findings will be commonly seen with the Zika virus. So these are the some of the important congenital infections that you have to remember. Next, we are going to moving on to the seizures. Okay, we are going to moving on to the seizures conditions, guys. So in the seizures conditions, we most importantly take note of the febrile seizures and absence seizures. Okay, febrile and the absence, because febrile is the most common. Okay, overall in the less than 1 year of the child, that is most common is the febrile seizures. And what is the drug of the choice for this patient? It is lorazepam or the diazepam. Lorazepam or the diazepam that you have to give. Absence seizures, this is associated with the patient especially in the 5 to 12 years, and the drug of the choice for this patient is the valporate. So because in the India valporate is only available. If you see no valporate, then you can choose the ethosuximide. Okay, ethosuximide you can choose if there is no valporate. Next, another conditions like Zan's syndrome. This is known as a myoclonic epilepsy, like juvenile myoclonic epilepsy. Here also the drug of the choice will be valporate. Next, you have the West syndrome. So in the West syndrome, the drug of the choice will be ACTH. But if you associated the West syndrome with the tuberous sclerosis, then we have to give the vigabatrin. Next, another syndrome like Dravet syndrome. So in the Dravet syndrome also valporate is given. Other condition like Lennox-Gastaut, and here also valporate is the drug of the choice. Next, SSPE. This is measles complication, right? For this patient, we can go for the carbamazepine. Carbamazepine is given. So these are the some of the seizures and their associated what are the drugs that you have to give. And so the here you can see there are the two kinds of the rashes, right? One is the complete purpura plus ecchymosis. Next, here only purpura. Okay, that is same. This is non-palpable and here palpable. So what is this conditions, guys? This purpura, the ecchymosis, this is meningococcemia. Okay, meningococcemia, and this is known as a severe condition, very detrimental condition. Next, this is known as a Henol's clinic purpura, right? Henol's clinic purpura. In the Henol's clinic purpura, this is known for the small vessel vasculitis condition, and usually these patients will be associated with the abdominal pain and joint pain, hematuria, right? This is the associated condition will be seen. And what is the treatment of the choice? Steroids. Next, here meningococcemia, the cause itself Neisseria meningitis, highly toxic, so they can also going into the shock. The baby will be death also, so much detrimental condition and highly transmitted by the droplets. So the treatment will be antibiotics. Next, moving on to the adrenal hyperplasia, congenital adrenal hyperplasia. In the congenital adrenal hyperplasia, the most common one is the 21 hydroxylase enzyme deficiency. Okay, this is autosomal recessive condition. So for this, what you have to understand, they are the two different, they are the effects. For example, 21 hydroxylase, 11 beta hydroxylase, and 17 alpha hydroxylase. So remember this way, blood pressure and androgens. So this is number first 2 and 1, and here 1 and 1, and here 1 and 7. So all the numbers of the 1 will be increasing. So here androgens will be increased in this patient. Here also in the 11 beta androgens increase, BP also increased in the 11 beta. Here also whichever is associated with the 1 number na, that is going to be increased. So the BP is low in the 21 hydroxylase, androgens is low in the 17 hydroxylase. So the number more than 1 is going to be decreased, the number associated with the 1 is increased. So these are the symptoms that is associated. Androgens is low, then the adrenal hyperplasia, which will be causing genital hypoplasia, right? And whichever who is having the androgens high, there will be a clitoromegaly. These kind of symptoms will be seen in this condition. Next, what is this condition, guys? This is known for the hypothyroidism, congenital hypothyroidism. What is the most common cause? Dysgenesis. Okay, dysgenesis is the most common cause for these babies. And what happens? The patient will be having the lethargy, and also there will be a umbilical hernia. Okay, umbilical hernia will be seen. Macroglossia, dry, and baby will be also having the hypothermia. This will be seen. What is the treatment of the choice for this patient? Replace the thyroid. Okay, replace the thyroid deficiency. Right, this is how we are going to treat these babies. So these are some of the important topics of our pediatrics. Please do read and follow up, and always practice the MCQs. Until then, see you guys and happy preparation. So those who are new to this channel, please do subscribe and share with your friends.